Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hey everyone, welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon. I'm a physician scientist at the University of Colorado, and I am joined today by Ashley Holt to a follow-up episode talking about some of the complications and considerations of these tumor-informed blood tests that can identify really low levels of tumor in the blood. Ashley, maybe you could introduce yourself a little bit and then we'll kick off.
Hi, yes. Happy to be here. So my name is Ashley Holt. I was diagnosed with stage 1 non-small cell lung cancer due to a ROS1 mutation back in October of 2024. Diagnosed in September. October was my lobectomy. After my lobectomy, I had some second opinions and decided, despite standard of care saying I needed a CT of my chest and abdomen every 6 months, I was going to do a CT of my chest and abdomen every 3 months for the first 2 years. And then also combine that with a blood test. I went with the Signatera blood test to, like you said, detect early signs of cancer reoccurrence. My first three 3-month scans were all good in that there was no evidence of reoccurrence in either the CT scan or the blood test. And then in September of this year, so my 1-year anniversary of diagnosis, the Signatera turned positive, which was very alarming. I had a scare and we had to do a PET scan, a brain MRI, and then also we chose to redraw the Signatera. So the last time that we talked, I was waiting on that redraw. And the good news is that that redraw was negative because Signatera says they have a 1% chance of a false positive. My oncologist wasn't as excited as I was to see it go negative. He was more cautiously optimistic and actually wanted to redraw it again. I needed a mental health break. Plus I had positive news on the PET scan and brain MRI. And so I chose to wait a month, kind of give myself a test vacation and wait 1 month. And so I ended up doing the redraw of that Signatera in November because and Kyle, please correct me if I'm wrong, but because the blood tests are constantly being updated, we decided to, when we redrew it in November, to start from scratch. So they took sample again of my tissue and did a new assay. Is that the correct term?
Yeah.
Okay. So they did a new assay. And so when I initially had it, those results took 6 to 8 weeks. So I was in a 6 to 8 week period of time where I was waiting for that redraw to come in. So it wasn't until the week of Christmas, actually, that I got that redraw done on the new kind of upgraded Signatera. And again, I had very good news in that it was negative. And because of that negative scan, my oncologist, or that negative blood test, my oncologist was willing to say that the test in September that showed positive results was a false positive. So you can imagine from September until the week of Christmas, I just had a lot of uncertainty and a lot of unknowns because of this test.
Yeah, and I think that's a great way to follow up, and I'm so happy that there's good news here. But these are, I think, one of the scary events that we talk about when we're counseling patients on should we do this or not. I think everyone inherently wants to do more things, and I think that's true for us too as providers. We want to offer more testing, more reassurance, more security. Feel like we're providing better service when we offer more things. But it's not very easy fully counsel on the potential downsides of some of these, particularly like what you're talking about. You had this false negative, or sorry, this false positive rather, where it was just weekly positive, just enough to give you this several month scare that cancer's coming back. And then, you know, all the anxiety and challenges that ensue. And I mean, it wasn't benign. It's not like, oh, you can just check again, or a scan will confirm. You needed a PET scan. You needed a brain MRI. You did a repeat draw twice.
Twice.
Yeah.
Because when they redrew it just like 2 weeks later, and we got the results back 2 weeks after the redraw. So they actually called the medical science liaison at the company because, again, the test says it's a 1% chance of false positive. So my oncologist wanted to speak to someone at the company and ask them, what do you make of this? It went back negative. And that medical science liaison said that it was more likely that I was experiencing a false negative with the redraw than the initial one was false positive. So, I mean, I'm not exaggerating when I say from September to the end of December, it was kind of hell, mental hell for me but I will say throughout this all, I stayed about as positive as one can stay, where I was like, you know what? I actually work at a pharmaceutical company and I work with medical science liaisons who I respect, and I'll often consult for the physicians that we call on, but they're just people too. And they're interpreting results. So I was like, that's one medical science liaison's opinion. And then I should also add, not only did I have to do all these additional testing, but for peace of mind and clarity, I flew to another hospital system for a second opinion because I wanted to take this so seriously. And that oncologist had a bit of a different opinion in that he believed I could absolutely be a false positive, mainly because, again, me being a stage 1 lung cancer patient, standard of care is not for me to get this blood test. And so the amount of data that they have on patients like me getting this blood test is inherently smaller. And then also, I'm a small subset anyways, right? Because 86% of lung cancer patients who are non-smokers get the diagnosis metastatic. So there's already a smaller pool of patients like me to have data on. So that was actually very reassuring, but you can imagine that costs money to get a second opinion. And it's also anxiety producing. Anytime I'm in a waiting room, I'm pretty anxious these days.
Well, and I mean, the cost and time of the scans, all the stuff that didn't necessarily need to happen. You weren't destined to get a PET scan and a brain MRI and all this stuff if this thing didn't pop weekly positive.
Yeah, absolutely. So it was a very hard period of time. And now, because of that, I'm actually in a period where I'm trying to decide what to do moving forward. So, like you said, it's really hard when you are offered additional testing that could find reoccurrence sooner to say no. But then, having gone through what I went through, I'm deciding literally this month, am I going to continue with 3-month scans or am I going to move to 6-month scans? So I am technically, if I wanted to continue with the every 3-month scans for my first 2 years, I would be due this month, but I haven't scheduled anything yet. And my oncologist is very supportive of me going to the 6 months, which would be May. I just don't know if I'll make it till May,
In terms of waiting that long?
Yeah.
Yeah. Well, I mean, in your mind, what are the trade-offs?
Well, mental health is definitely a trade-off, right? Because I absolutely I am the, star example of what can happen when you ask for additional testing and you can have these false scares. So I would say right now, It's February. We're a couple months out from Christmas. I'm starting again to feel better and not thinking about cancer all the time. I still think about it daily, but I'm not thinking about it all the time. And that's a nice feeling that I am very lucky, by the way, to have. I know not everyone gets that luxury because they're doing adjunct therapy and other things. And so it's always on their mind. So it's been nice to start to get back towards a place of normalcy for myself. But, at night when you can't sleep and you're like, why wouldn't you get the scan at 3 months? Just to make sure the sooner they catch things, obviously, the better. So that's the trade-off. Catching it earlier if it were to come back versus just doing additional testing that's causing the anxiety.
Well, and built into that anxiety is the assumption that catching it earlier means you do better. And that is an assumption.
Yeah.
It's a hard one to ignore, because the overwhelming sense is the sooner you catch it, the less likely bad things are going to happen. And on the whole, that's certainly true. But when someone's heavily monitored, the every 3 to 6 month recommendation that your doctor provided you didn't come out of thin air. Like that was evaluated to say, how frequently do we need to monitor people? And then, if something's slow growing, if something's pretty indolent, meaning like a non-aggressive cancer, you were identified at stage 1, a small cancer, they cut it out, they thought they got it all. Is the extra growth of 3 months versus 5 or 6, is if you were to have missed it, so to speak, if you didn't do that scan, is that extra growth meaningful, or do you just radiate it anyway? So it's it's an interesting conversation that we have around this kind of stuff. It's a lot of times the real reason we're doing these extra things is to alleviate anxiety, even when we think the extra time isn't going to change much, or that at least the likelihood that the outcome would be worse is low. So really, you're alleviating anxiety for the most part. And the flip side of that, the irony of that, is the extra testing that we're doing to try to alleviate anxiety is worsening the anxiety.
I really feel that. And that's why it's like catch-22 for me. I don't really know, talking to you today, mid-February, where I'm going to land on this. I can almost guarantee I won't, because I haven't scheduled anything yet, that I won't get it this month. But I think at some point, the anxiety of not knowing and waiting will outweigh my fear of the anxiety waiting for the test. Because the further I get out, the less I remember how terrible it was. Like from September, and that scare was terrible. It set me back all the way back to a year ago when I got the initial diagnosis and all the fears. So, yeah.
Yeah, and the irony of that is if you didn't do that test, you'd probably be at 6-month scans or something.
Yes.
And all of that just wouldn't have happened.
Yeah.
You didn't miss anything, but you would have not undergone a PET scan, a brain MRI, had to sit down, wait for those tests to come back, wait to talk to your doctor.
Additional Signateras.
Yeah, wait for each of those to come back. One came back negative, you're reassured, your doctor's less reassured because the company says this is rare. And they're like, okay, well, I guess this is not over yet. So, I mean, it's months of, I think I have cancer. And all of that could have been avoided by just not doing the test.
Yeah. And I would say once I got that first redraw negative, I chilled out. So that month from when the redraw came back, or the initial test came back positive, to that first negative was really terrible.
Yeah.
Really terrible. But I just kept saying, I'm going to be the 1%. I kept saying it in my head, I'm going to be the 1%. And I did those techniques to try to make things. I'm raising 2 little kids. I have a demanding job. I travel, all these things that I can use to distract myself. And then also at night, midnight on the night you can't sleep when you're wrestling with all of these different terrible thoughts. That's what I kept trying to come back to. But I would not wish what I did on anyone, especially myself again. So it is kind of interesting that I'm still considering. It's just hard. When you're given that option to do additional testing, I don't know many people that would say no, but I might be that person now, right? I can almost guarantee I'm not getting the scan at 3 months. So,
well, I think part of the impetus, much of the impetus needs to be on the physicians to say, what is the likelihood, of false positive, false negative? When we're doing this, how much incremental benefit do I think it offers? And I think that's the issue of being at the cutting edge. And my point here is not to say one should or shouldn't do these testing. Like that, the only point I'm trying to make here is be appropriately informed of the risk and benefits. And I think at the cutting edge, it's really hard to do that. As a clinician, it's hard to do that. As a patient, it's hard to do that. Let me ask you, when you were involved in any of the social media interactions, patient advocacy organizations, did you hear anyone talking about risks to these tests?
no, I don't think so. I think most of the people that I speak with regularly are so immersed in it and see so much just sadness that can come with cancer and the disease, and the idea that there's tests out there that could help someone live longer. It's really just framed in a positive way. And I will say, though, that the reason that I went to 3-month scans and pushed for the Signatera was because my second opinion said this is what I would do.
Mm-hmm.
Now, he also counseled me on the fact that this is really up to you, though, and what you're willing to put yourself through, knowing that scanxiety is real. So he said at any time you could switch and go to the standard of care. But this is what I want to tell you is available to you. This is available to you. He also had a very different kind of view on Signatera, where even though the company says 1% false positive, he always thinks of that test as just another piece of information, nothing that you react on, just something that would lead to additional testing. Like in his eyes, getting this blood test, all it means is if it turns positive, you get a PET scan and a brain MRI. That's all that it means to him. It's pretty cut and dry. Where my oncologist in my hometown that is actually managing my care took that positive as we have to act. Mm-hmm. I mean, he still ordered the brain MRI and PET scan in the similar way, right? That signals we have to do additional testing, but he was pretty adamant that we would need to start some medication right away as well. So that's the other thing that you're at risk of. Depending on who you talk to, you could get wildly different information. And then I have the luxury of working in the industry. And so I have friends who work specifically in pharmaceutical sales for oncology. So they were at a conference and Signatera was there. And so they actually went up and spoke to the sales rep. And I very much respect those people in that industry because that's what I do. And I asked them to ask them, because in my opinion, if someone's selling a test, they're really going to know, how it should be used, what would be considered off-label, all of that. So I'm a lucky person to kind of have this wealth of knowledge that not everyone has.
Yeah.
So I would really caution people as well, if you're thinking about getting this additional testing, making sure that not only your doctor is explaining the risks to you, but that you understand them. Because I certainly did not. I did not understand what it would mean.
Well, and this is evolving over time too. I think a lot of the doctors prescribing these, myself included, don't know the full extent of all the studies that are currently going on. We know that it's a blood test, and the way the blood test works is it looks for a unique thumbprint, so to speak. This is DNA signatures, DNA mutations in the tumor itself that is theoretically different from the rest of the body. So it can identify mutated DNA that is specific to the tumor. And the reason that's important is when you draw blood, you have DNA in the blood. Most of the DNA in the blood is not from a tumor. It's mostly from white blood cells, it's from other things. All that's going to be normal DNA. And then what these tests do is they say, is there any bit of that mutated tumor DNA in there? And this could be 0.1% of all the DNA they see, really, really small fractions. But if they have enough of those elements of a fingerprint, they can say with some certainty that we see a little bit of this. It's probably at, what percentage? And yours came back at a very, very low percentage, which should raise some concern that maybe there's a little bit of noise in that signal and it's calling something, very weakly positive. But we've been down this road before in medical testing, and we know that weak positives can sometimes just be, it can just be noise. And then you do the redraws and you do all these things. But we know that the purpose of this test is to identify really low levels of that tumor DNA. What we haven't fully ironed out is, does knowing that information sooner change outcomes?
Yes. Yeah. I know it's hard. It's interesting when you explain it like that too, that the assumption is catching it earlier will lead to a better outcome. Because you're a data guy, you're a clinician. So I understand what you're saying, but I know what you mean. Like, this is a slow growing cancer. And
these can identify these tumors before you can see them on a scan. So, and for some people, it could be a while before you would see it on a scan. So then you have this knowledge now that's like, you have cancer somewhere in your body. I don't know where it is. We could just keep scanning you every month, 2 months, 3 months, waiting to find it early. And then you're living in this perpetual state of, when is this cancer going to break out and grow? But if we just scanned you at the regular interval, we would have just seen it there anyway.
But I will say, my second opinion, doctor, the way he explained it to me and how I want to think of the test moving forward is, it raises that alarm that cancer's in there. And my standard of care is only a CT of my chest and abdomen. Mm-hmm. So I like how, if that goes positive, then you go to PET scan and brain MRI to check the places that you wouldn't check with your standard of care scan. Right?
Sure. But does that matter?
Yeah. I mean,
we don't know.
It definitely gave me peace of mind then to see the PET scan was clean and the brain MRI was clean.
And that's part of my argument is that's what we're doing is offering, in theory, peace of mind.
From a huge scare.
Right. But if you didn't do it, you would have had the peace of mind to begin with.
Yeah.
We instilled the fear,
Oh, I mean, 100%. The additional testing that I asked for led to a few months of hell for me. 100%.
Yeah, I think the question I think many patients don't ask, and clinicians don't really necessarily think to reconcile, because clinic visits are busy. You have other stuff going on. This is kind of a throwaway add-on a lot of the times, but a lot of the time you could ask this question where, what's the likelihood that I will do better if we add this test versus don't? And that's a different question than, do you think this could catch it earlier, or how much sooner could we catch it? What are we going to do if it's positive? And those are all questions we should ask too. But in the best case situation, you catch it earlier, or let's say it's positive earlier. You do all the scans, you identify a growth, a tumor progression area, and now you've identified it 1 month earlier than you would have with the routine scans. Do you think that's going to matter? And I think that's an important question to ask, because that's really how you determine if the test is beneficial or not, is Well, doing this
But
test,
what if it doesn't reoccur? Like, let's say I went with standard of care and only got CT scans of my chest and abdomen every 6 months, but the cancer reoccurs in a different spot that's not visible. Then that Signatera saves like your
sure,
life.
but what's the
Doesn't
likelihood
it?
of that happening?
Is it so you tell okay, so is it not likely to
Right.
reoccur
That's why
elsewhere?
those scans don't cover those areas.
Oh, I see. I see. And this is the thing. I'm going to be honest because of the advocacy groups that I'm involved in. I guess I wasn't aware of that. Obviously, I know reoccurrence is more likely in those areas because that's why it's recommended to get a CT of your chest and abdomen. And like you said, that doesn't come out of thin air. That's heavily studied to be made standard of care, right? Um, but I guess, and even my primary oncologist had made the comment that he has seen people come back where it reoccurred somewhere else. But
It can happen. It's very rare, and yeah, it's very rare. And usually, the way those surveillance scans go is you would follow those guidelines, and then if there's a symptom, you would chase it. Um, but no, I think that it's always on a spectrum of risk and benefit, and I think we are getting closer as a society to do all the things all the time. Because you have the spectrum. You could scan your brain, your chest, do the blood test every day. Like that could be your life. You just go in, you go for your daily scans, you go for your daily blood test. And the other side of, that risk benefit reward is, you never do it or you do it once every 5 years. Somewhere in the middle is a sweet spot. And I'm not saying that we've perfectly found it with our existing tools, and tools evolve. So this is going to keep changing. And I think these blood tests are going to incorporate into that, as they should. I think they're a really, really good uh, discovery. These tools are really good inventions. But I think we're at a point right now where how we utilize them, we're still figuring that out.
yeah.
And we're really quick to talk about the benefits. And the benefits are, I think are potentially strong, but we don't have really great data right now, to your point, to say what really is the added value of these in all circumstances.
And I don't think patients know to ask those questions because I'm pretty well informed and I didn't think to ask. So, what happens if this turns positive? What does that mean for me? I just said, yes, I want additional testing. And in fact, I was pretty adamant that I didn't want standard of care because I'm 30. Well, now I'm almost 40, but I was 38. And in my head, I don't think standard of care is necessarily the right. I understand standard of care probably is very appropriate for someone who's maybe in their 70s or something like that. But for me, raising two young kids, I just initially thought the more the better because I want every additional day I can get. And so that's why I signed up for it without asking many questions. I do put a lot of trust too into the physicians, and obviously I sought out a second opinion. So when my second opinion told me about this as an option, I just kind of went with it.
Well, you're mentioning, I think, a common conception, which is standard of care, meaning what we recommend for everyone, is a step below what we can do. Like there's a hierarchy of level goodness of care. Uh, and I don't think that's true. I
Mm-hmm.
think we have standard of care, which is the Goldilocks. That's where we went on the risks and benefits, and we're keeping in mind the risks you went through. How worth it is it to have someone living in anxiety, chasing all these things, all these added scans, all the added money, time lost from work, things like that? And what's the likelihood you're going to catch something? Incredibly low. So standard of care is usually that Goldilocks area, acknowledging that more is not always better. But I think there is this perception that when we say, we have standard of care originated from the best trials that were positive, that like gave us the best data.
I know, but
Like, that's
also
where
because I'm in this industry, I see how long it takes recommendations to get updated. So,
yeah,
like that, because I work in gastroenterology, for example, and the medication that I sell and the disease state that's for, the guidelines, it takes years for them to come back together. And they just had an update, but it was like 6 years between the updates.
I'll say cancer moves faster than that, but there is still a delay. And that is where the conversation with the oncologist needs to come in to say, is this something that we should all be doing? And I think this is a great example because all of our practices are evolving in real time. My practice is evolving in real time. I'm being critical on the assay right now in your circumstance.
Yeah.
But this isn't to say that I would have done anything different. I might have also recommended it. I might have also, had this sentiment that this will allow us to catch it early. There's a real chance that if you were in my clinic, we would have come to the same agreement.
And I think what I learned is to really ask secondary questions about these sorts of things, whether it's scans, blood tests, appointments, whatever, to understand what you're saying yes or no to. Because I think that could have saved me a lot of anxiety had I done that, right? If my oncologist would have called and said the Signatera turned positive, I could have said, okay, so this is a warning bell. We have to take this seriously. It's going to lead to additional tests, but it could be nothing. But that is not the message that I got from my oncologist. And yeah, so had I stayed with, for example, had I stayed with my physician who I got the second opinion from, I think that call would have been very different when he got the positive Signatera. I don't think he would have been as alarmed as my primary oncologist. And I just took on the seriousness of the call from the doctor who called me with the test. And it was hard to ignore that. So I really thought the cancer was coming back with like certainty because I just kept thinking about how he said it's only 1% false positive.
Yeah, and it's tough. I think these are evolving tests and they're complicated tests. And so I think we as providers in an ever-evolving landscape are kind of limited by the information we get from these drug companies. And the drug companies they're well-intended scientists and the medical science liaisons, the people who work with us to try to understand the assays. Everyone's really well-intended, but they do talk up their assay. This is a competitive field.
Oh, 100%.
You got Signatera, but that's one of many tests.
How many are there?
I don't know off the top of my head. I think there are 3 that are commonly used, but
Okay.
but there are many, and I
didn't even know that.
Well, there are more that are coming out that work on DNA methylation signatures, and you have all these different things. So the company is gonna spin their data, or at least highlight their data, in the most flattering way. Everyone does this, and I would, you don't blame them for doing that, but that 1% false positive, digging into a little more, like, well, what did you mean by positive when you ran that test? Was it the same degree of positive that I am now? Would I even have been a positive?
Yeah.
My suspicion for you is when the test was run, when the clinical tests were run to determine what is positive and negative, your level may have been negative. But as the assay gets more and more sensitive, now they're able to detect something where before that would have just been called noise.
That makes sense. Yeah. That's interesting too, because I didn't ever think, I just went with the test that my oncologist ordered. So I didn't do any digging to like understand the difference between them or anything like that.
Well, and I don't know that you should. I don't know that it's hard enough for us to keep up to date, as evidenced by the way this false positive went down. This isn't, I'm not aiming to blame any of the clinicians involved. It's just to say that at the cutting edge, this stuff's really hard. And the best thing that one can do when they're trying to get what they think is best care. And I don't say that with judgment. I mean, we often don't know yet because it
Mhm.
takes time to figure that out. But if you're getting all the new stuff, be prepared to ask additional follow-up questions and really understand, are you getting the benefit you think you're getting? Or, like the example I gave earlier is, if I could tell you you were going to get cancer somewhere in 5 years, would you want to know? And most people would say, yeah, but then you'd be doing this additional testing every however long, just waiting. And it's like, well, or if you just found out 5 years from now, would that have been better? And that's a tough kind of philosophical question to reconcile. And one we
And
often,
every person's answer is probably different,
yeah, it's tough. It's the would you want to know the day you're going to die kind of thing. And usually the differentiation point is, can I do something about it or can I not? And this falls in a really elegant gray area to say, could I do something? Maybe. We don't know if
Yeah.
having that blood test earlier is going to change care in a way that's going to matter. We just don't know that for many people yet. That being said, we tend to err on the side of, if something is potentially helpful, we want to do it because you have the potential for benefit, but we don't always do the greatest job of discussing the potential for harm. And people in their mind think the intellectual harms are trivial. And I think that's something that's really hard to relay as a provider, and even to, I imagine, to your peers, to say, look, having this as a positive test, that's a greater harm than you may think.
Oh, absolutely. I mean, it robs me of time with my children. It
Yeah.
robs me of joy. I mean, it's those months where I was waiting to get the final answer of, this was a false positive. There's, the likelihood of reoccurrence, it still remains very low given your stage 1 initial diagnosis. It was challenging. And I was going through the holidays too. Thanksgiving and all of that. And when you're reflecting on what you're thankful for, and it's very emotional and it's hard, especially when I was in this point where I was starting to move forward with my life. And I felt like I was right back in it, of this unknown and uncertainty. So yeah, it's definitely not trivial. And I do not think I thought about that either when I signed up for the additional testing.
Yeah, I think as a clinician, I'm as guilty of it as anybody. I recommend these tests, and the counseling is very quick. They're very busy clinic encounters, and usually I'll have the time to go through, what are we going to do if this is positive? And like you're saying, a lot of time it's, I like to get these tests not necessarily at the same time we're getting a scan, but maybe at a halfway point kind of thing. And then if it's positive, you move your scan and try to catch something earlier. That's kind of where my practice is currently landing. And even still, that's for the right patient. But then the next level of nuance to, okay, well, let's talk about what happens if the test is positive, the scan is negative. Then we're in this really uncharted territory, which you found yourself in, but it's one I fear as someone who orders these tests. Because then, when do you next scan? Like,
Yeah.
would I have caught it a week from now? Would I have caught it a month from now? 3 months? Do you just continue your norm, like what you were going to do, knowing this test is positive and you can't see it? So I think it's interesting, the rate of, I guess, technological advancement in this field is exceeding the rate that the studies can answer these questions, I think. Because so many companies have different tests out now. They have different levels of sensitivity. That's going to influence how you monitor and how you react to change. So,
Well, and now there's all these tests that are being promoted for people who haven't had cancer as well, like places where you can go as just a healthy individual with a PET scan. And I think about that because my lung cancer was found in an incidental finding.
Mm-hmm.
I had no symptoms. And in a way, I got very lucky, right? And that's how we were able to catch it so early. So I understand why people want to get these, but I can tell you, because I have to get breast MRIs every 6 months, because in the period of time where we were getting my diagnosis, they found a couple lumps in one of my breasts. And so this is like ongoing. I am about to get my third breast MRI because of what they found. And I don't really see an end in sight. I feel like it's either going to finally get to a point where they're like, we need to biopsy them, or we just keep doing them every 6 months because there's 2 lumps there.
Well, and in a world of the least amount of risk tolerance, you get the most amount of testing. And the United States in particular, more than probably any other country, has a very, very low risk tolerance. So we do by far the most testing. Our healthcare expenditures are through the roof. But these are the reasons why. Is every incidental thing that we see, we follow up and we follow up, and you're doing all this extra testing. My concern for these blood tests that say they can identify any type of cancer, or at least they can identify that there is cancer there. One, a ton of people have cancers in their body that are not going to cause them problems. By the time a male reaches, in their 70s, they're more likely to die with prostate cancer than from it. So, like, what happens when we have to reconcile that? And even for you, the tumor in your lung, I don't know that was ever going to cause a problem. My training and my, I guess, scientific background makes me think at one time it probably would. So I'm happy we took it out. But we don't really have a practice of identifying tumors and not taking them out. So I don't know what that would do. Maybe you would have lived your whole life and it would have grown in a centimeter. I don't know. But that's certainly true for certain prostate cancers. So what happens?
Is it thyroid cancer one of those too, where it's very, like, I feel like you can get even like a higher grade thyroid cancer and your outcomes are still usually very, very good.
Yep. Okay. Certain thyroid cancers are really, really mild. There's a lot of cancers that one can develop and still, even metastatic testicular cancer is largely curable, depending on the type. There's a lot of examples where you're going to find these things with these blood tests. You're going to do this scan, and let's say the scan, you identify these prostate cancers, or one of these examples, and okay, I guess we watch it now. Or you do a scan and you don't see anything. Like, now what? And you repeat the test, still positive, and there's nothing to see. Like, I don't know what to do then, and I think a ton of people are going to fall in that bucket.
Yeah, I think it's hard as an individual because the word cancer comes with so many fears. And, we're all used to, this is probably a terrible example, but we all get colds all the time. Like, no one's scared of colds, but everyone knows someone who died too early from cancer. And there's so many fears that come with it. And even on my block, I mean, there's young women on my block who have had colon cancer, breast cancer, and myself with lung cancer. Oh, and ovarian cancer. All on my block. Like, I don't know if I don't know. People are scared. And so these companies are making these tests available. And I feel like more people are going to start doing them.
Yeah.
And what does that look like for you as an oncologist?
And I'm not even going to come down and say that it's a bad thing.
Yeah.
I am going to come down and say that it certainly shakes the hornet's nest here. It has a tremendous amount of ambiguity, and we're not going to know how to reconcile what to do with these tests for a while. particularly the cancer detection tests, which, you know, who wouldn't want that, right? Like, who wouldn't want the opportunity to identify something potentially lethal? But what happens when you identify something that's either A, not lethal, or B, not radiographically evident? Like, I can't even see anything. And
Yeah.
then you're just like, oh, I have a diagnosis of cancer, and you're walking around. I mean, there are many people, and this is a common, well, I don't know how common, but it's a psychiatric condition that occurs where people are very, very convinced they have cancer. And they come to us and we have no evidence of cancer, but they know they have cancer. And that is living with that is hell. Like, we cannot reassure them they don't. And they are very convinced they're going to die of something that we can't help them from. So when you actually have a blood test that tells you that's the case,
Yeah.
like, I wouldn't wish that on someone. And who's going to adjust the sensitivity of that blood test to say, only if you have this much of that signal are we going to call it positive, and if it's lower, we're just going to ignore it. Like, no one's going to do
Well,
that.
what do you even do with that information until you know where the cancer is? That's the thing. Like,
Right. I mean, you scan and you look for it, and if you see it, great. And of course, there's going to be examples of that, and I think it would save lives. But at what cost? How many people are going to go through all this stuff?
especially if the companies are saying we have a 1% chance of false positive. Like,
1% on the entire population is a lot of people.
yeah, so that's a good point, actually. But still, I mean, as you can see, you can be the 1%. I'm the 1%. And
Unfortunately, not the traditional top 1%.
no, definitely not.
Yeah. This is a very different 1% than.
But it's just scary to think. I don't know that I would want to risk doing that test to find some sort of evidence of something that you can't see on a scan.
But you don't know until you do the scan.
Yeah, that's true. Yeah. Like you said, it would save lives. It would definitely save lives. And it would also cause a lot of anxiety in people for no reason.
Well, then all this stuff you find, like you're mentioning the abnormalities with breast imaging, and now you have to go get repeated, breast MRIs. That's going to happen to a lot of people.
Oh my gosh. And it's hell because once you have had cancer, there is a certain level of trauma that is just there when you go into these scans. And so even though I haven't had breast cancer because of the lung cancer, anytime I have to get a CT, an MRI, a PET scan, it is very anxiety provoking. So these 6-month breast MRIs are very frustrating for me. And then I'm in a waiting period too. They take a couple of weeks to read. And I know that there's going to be lumps there. Like, they already found 2. So they haven't gone away. They're just making sure they don't grow or change significantly. So it's, yeah. And then at what point do they say biopsy? And then that's a procedure. So for right now, they just keep saying they look benign. Even the radiologist who's reading these is saying they look benign. I'm like, well, then why do I have to keep coming back?
Right. Well, and there's like all this stuff you're doing, and let's say at some point it goes to biopsy, and then you get a biopsy and it's a fibroadenoma, it's something benign that's not cancer. And then it's like, so just to be clear, this whole time I could have just ignored this and not have to deal with any of this, and it would have been fine.
And this one for me, I actually have pushed out past the 6 months. Maybe it's just because I didn't have breast cancer that I feel more comfortable with that versus pushing out a cancer that, is more related to my lung. But I just get frustrated with this test because I feel like they have to keep saying repeat for fear that, like, malpractice. Am I reading this wrong? I'm like, why do I keep having to come back? You're saying even on imaging, it doesn't look like anything.
No, the risk of litigation is very real. I wouldn't say that's usually what is at the forefront of our minds, but I would say it's definitely in the back of our minds that if you if a radiologist, I'll start with the radiologist. If a radiologist sees something abnormal and they don't call it out and it ends up being cancer, they can certainly be sued. If they see something that could potentially turn into a cancer, like a breast lump that looks okay, but sometimes those can take off, and they don't say follow it up in 6 months or with some reasonable interval, and it ends up being cancer, they can be sued. If I see that report and I say, oh, don't do that, and it ends up being cancer, I could be sued. I think we want to do what's best for the patient, but we also acknowledge that in our environment here, there's not a lot of tolerance for not doing things unless you have a really clear risk benefits discussion.
Like the patient has to be the one. Like in this instance, for example, I was actually due for my repeat 6 months scan in like December, and I'm not doing it until this March. So, because I'm just fed up with it.
Well, and I think that's totally okay. But I agree the patient has to be the one to land on that in our healthcare system. I don't think that's true in other healthcare systems. And, who's to say what's better or worse? But it's tough as the patient to say no to things, to say no to the most aggressive scanning, to, the most aggressive follow-up, the additional blood tests. And it's really hard to conceptualize the risks and the detriment of over-testing, which is what we in the healthcare community, we try to combat over-testing. And it's really, really, really hard.
I can completely understand that, being someone who signed up for additional testing. And also, I'm probably going to go closer to standard of care moving forward because of what I went through.
Yeah, and I don't know how to alleviate the misconception that standard of care is subpar. Like, it's not.
I don't want to be a spokesperson for it, by the way. Like, I don't want to be a spokesperson in any way. I like to speak of my experience so people can learn from it. But hey, you do you. Like, if more testing is offered to you and that gives you peace of mind, you should do that, Yeah. I think the thing is you just have to really internally ask yourself, because we've already kind of discussed that in the US, you can get more testing for the most part, dependent on your insurance, of course. But I'm just saying, like, I don't want people to think I'm saying don't do it either. I want people to understand the experience that I went through, though, because I certainly didn't think about what additional testing could cause as far as the induced anxiety that was unnecessary.
But I've seen so many examples of patients who want more testing, higher doses of something, more frequent doses of things, additional regimens added on, more. And it's really to combat an emotional crisis. But we don't have a lot of evidence that any of those things that I just mentioned beyond what we recommend adds to their benefit. And many of the time it is known to be worse,
from a quality of life standpoint or
even
quantity of days.
It can be both.
Some people are fighting for days.
Yeah. But it can, if we escalate treatment doses, if we add on, additional chemotherapies, for example, beyond what's recommended, that can actually lessen people's time because of the toxicities and things like that. But I know many patients who they'll seek out second opinions until they get more and more regimens added on, more and more therapies added on. And it's really hard to decouple the emotional benefit of doing everything you can and then the known physical risks that all these things you're doing are almost certainly hurting you. And it's a tough balance in cancer when control is largely taken away.
Yeah.
And people can regain control by doing the more things, but it's really, really hard to counsel the costs.
So having experienced a physician who did walk me through all of what it would mean if it was positive, I would say that's what I would like more physicians to do is really talk through that. But at the end of the day, the patient definitely drives a lot of this, and it's shared decision making. So we have to take on this responsibility to really understand what we're asking for as well.
Yeah, and I would keep in mind that physicians are doing the best that they can with the tools that they have, and the tools that they have are evolving. So, I mean, you had multiple different recommendations following that positive test.
Absolutely.
Because we're all figuring it out in real time. We're talking to each other. So I think we're very much in this together.
And I would like to view that as a positive, though. That's a blessing that things are moving so fast that, we can't always, standard of care can't evolve always as fast enough, or each physician can't possibly know. I mean, we're all humans here. And luckily, we're in an age where patients do have a lot of access to understand this sort of information. I also don't want to sound naive to the fact, though, that a lot of people absolutely cannot navigate this information. And so it's just challenging. There's more access, but that doesn't necessarily mean everyone has it.
Yeah, I think that's definitely a fair point. And the nuances of these tests, because the tests are very complicated, the nuances are really hard to understand to the well-trained clinician who uses them. They can be hard to understand. All these tests are different, and they're doing very complicated DNA sequencing methodologies that, these are not easy things to get in real time as we're deploying them and counseling patients. There's a lot to know, and we're just not there yet. Any last sentiments, Ashley, before maybe we wrap up here?
No, I think it'll be interesting to see where I land. The surveillance after my lobectomy was set at 5 years, but even that was something that I got different opinions on as well, as if, it might be for life that I have some sort of monitoring, whether that goes to a scan every couple of years even. So this isn't something I'm going to run away from. It's with me. I'm going to be in some sort of testing pattern. And so I just am going to try to continue to evolve with it.
Yeah. No, I think wise words. Well, all right, everybody. Hope you enjoyed this follow-up here. And Ashley, thanks so much for coming back on and kind of ironing out the end of the saga.
Yeah, these are like therapy sessions for me. So thank you.
Yeah. The bill's in the mail.
Sounds good.
All right. Thanks, everyone. You can go to crackingcancer.org for more information. All right. We'll see you later. Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.